Dr. Kamaljeet Singh, who is the assistant professor of pathology at Brown University, and he's going to give a presentation on high-yield topics for boards. So thank you, Dr. Singh, for being with us. So it's over to you, Dr. Singh. Thanks a lot.
Hi guys. So as Rifat said, I'm going to just present this PowerPoint presentation that my intentions were to enrich it with the pictures of the breast cases, and that could be useful for people who are taking boards. And I'm not sure about that, so I actually put it in quotations like high yield. So hopefully that this would help. This would be helpful. And thank you, Rifat, for arranging this. So let's get started. So first, I think this is a very common theme. This you see it in breast every time. UDH versus ADH. So UDH is usual type ductal hyperplasia. ADH is atypical type ductal hyperplasia, and it seems easy, but actually the kappa score, the inter-observer agreement on identifying ADH is very low. It's 0.18. So on the picture on the left is ADH, and what defines ADH is the architecture and the cytological features. So by architecture, I mean the cells, the epithelial proliferation. It makes this round, very well punched out spaces. Well, in UDH, the spaces are of variable size, shape, and usually the larger spaces are on the periphery, and in the center you see more smaller or slit-like spaces. So that's the architecture, and the cytological features are also as important. So in ADH, you see these microacini that are the polarized duct spaces. You don't see that in UDH. The spaces are more, as I said, slit-spaced. And this nuclei in UDH, they seem to swirl. And the appearance is that you can see some darker nuclei, some opened up nuclei, while in ADH, the nuclei are more uniform, round to oval. So that makes it ADH. So there are a bunch of patterns that ADH you can see in ADH. One of them is this micropapillary, which in this picture is very obvious, or I would say overt, but they can be subtle, like what you see in Gynecomastia, and we will look at the picture later. So in a micropapillary architecture, what you want to see is a narrow base, and actually it's like a club shape, and the size of the nuclei at the top is almost the same as what you see at the bottom. So that would make it a ADH, micropapillary type ADH. And there are immunostains that you can do to differentiate UDH versus ADH. And if morphologically the proliferation is ambiguous, you can use CK56 and ER. And we'll go over this and when we talk about the papillary lesion, how to separate ADH from UDH. So let's go on to the papillary world, and these are the lesions which we will be covering. Let's start with the intraductal papilloma. So this is one of the core biopsy from an intraductal papilloma, and what you are expecting is in a benign intraductal papilloma are this hyalinized, overt, big fibrovascular cores, and which are present with with epithelial proliferation, which on a closer look looks like usual type ductal hyperplasia. So there's a mixed population of cells, and if you go focus on individual papilla, you want to see two population of cells. There are myopithelial cells, and then there are luminal cells. And most of the spaces or the epithelial proliferation has features of usual type ductal hyperplasia. But what makes things complex is sometimes you can have apocrine change, and it can look like atypical. So here's where the CK56 and ER can help. So what you want to see in usual type ductal hyperplasia in a papilloma is a mosaic pattern, so it's a cytoplasmic stain, and it would stain. In UDH, there will be a staining. So there will be some cells that are negative, but then there will be mixed cells that are positive. So CK56 also stains the myopithelial cell, so it's helpful in that way too. But what you don't, so if you are expecting ADH, what you would see is sheets of a focal area in which the CK56 is totally lost. However, the caveat is if there's an apocrine change, that would be CK56 negative. So what you want to do is combine it with a estrogen receptor ER stain. And if this focus was ADH, this would be strongly ER positive. So you will see some ER staining in every epithelial proliferation, but to call it ADH, you want like diffuse, strong nuclear staining and corresponding absence of CK5-6. So this actually proves that it's actually a apocrine change in a papilloma. So this would make it an intraductal papilloma with florid usual ductal hyperplasia. So I bet you have seen this picture before. And in a papillary lesion, what you're looking for is presence of myopithelial cells, and you're looking at it two locations. One is in the papillary core, and the second is at the junction of the lesion with the breast parenchyma. So in a benign papilloma, you have it at the both spots. So in a papilloma with ADH, what would happen is you have a benign appearing papilloma, and at the same time you have this atypical proliferation with features of ADH. There are this is you can see the punched out spaces. The cells are monomorphic, and if you do CK5-6, this would be negative, and it will be strongly ER positive. So if you have concerns, you can do that stain and confirm it as ADH involving a papilloma. How about the DCIS involving a papilloma? How do you make that diagnosis? And we are talking about low-grade DCIS. So this is another lesion, corneal biopsy. This is a little different from the previous biopsy. It's more solid, and it's sort of sclerotic, multinodular appearance. And on high power, you can see most of the proliferation is made of this rounded acini. And so first thing you got to do is, are there any myopithelial cells? So you do a morphological evaluation. I don't see any. So, but you can certainly do myopithelial stains and CK5-6 ER. So CK5-6 is almost negative. There's some focal staining, but entire lesion, it's totally negative. There's myopithelial stain. So this is P63. It's a nuclear stain, and you see there are some residual myopithelial cells. However, in the center of the proliferation, there are none. So this would make it a typical. And ER is strongly positive in the lesion. So this is a typical, you can call it a typical papilloma, but the right diagnosis is papilloma with at least ADH. Now, does it make it to DCIS? So you have to go to the WHOs, and I'll get to that, like how much ADH makes it to DCIS in a papilloma. So there are criteria for that. So this is another case of a papilloma in which you have this central sclerotic area, and there is usual type ductal hyperplasia in the top half, and there is this atypical proliferation which is sort of strikes out as distinct, and there are occasional mitotic activity. So P63 immunostain shows loss of myopithelial cells in these atypical areas. However, there's some preserved myopithelial cells at the periphery. So, and it's present as a sheet. So this will make it to papilloma with DCIS. So the cutoff is 3 millimeters. So if you have a linear span of ADH that measures at least 3 millimeters, the WHO 2012 edition, the working group says you can call it DCIS, low-grade DCIS. So what we have talked so far is where do you look for myopithelial cells in a papilloma, and how to call it ADH and DCIS. So myopithelial cells have to be present at the periphery, and they will be present in the papillary cores in a papilloma, and they will be absent in the papillary cores in ADH or DCIS in a papilloma. So going to the criteria to call ADH versus DCIS in a papilloma. So less than 3 millimeter, call it papilloma with ADH. More than 3 millimeter, to call DCIS, more than or equal to. There are other criteria out there. Some people call DCIS if at least 90% of the lesion is made of this atypical proliferation. So there are percentage criteria, but these are coming from WHO, the linear extent criteria. So papillary DCIS. So papillary DCIS will strike you as a papillary lesion. So how would you pick it? It will look like the papillary cores are thin, usually. They're not sclerosed. And the proliferation involving the papillary cores is comprised of elongated cells. They are overlapping. There are no myopithelial cells. It almost looks like a villus adenoma, if you say. And it's actually rare. It's actually one of the rare form of DCIS. So before you're making a diagnosis of papillary DCIS in board or in a general practice, just think, are you looking at a papilloma with DCIS? Because that's far more common than true papillary DCIS. So what do you expect if you do a myopithelial stain? So this is smooth muscle myosin. It's a cytoplasmic stain. It highlights the myopithelial cells at the periphery, at the interface, and there are no myopithelial cells in the cores. So that would make it a papillary DCIS. What about some benign papillary lesions? Papillomatosis it's a condition where you have small papillomas, small peripheral papillomas. So there's a cutoff suggested of 3 millimeters for a small peripheral papilloma. It can be smaller or slightly larger, but if you have, when do you call something papillomatosis? When you have multiple small benign papillomas in breast tissue, you can label it as papillomatosis. There's another term, juvenile papillomatosis, where in addition to the small peripheral papillomas, you also have apocrine cysts, and the patient presents as a sort of vague mass. I mean, it's called juvenile papillomatosis, but it can present in adult and older females. So something that can be tested on both. All you will see is papillomatosis and some apocrine cysts. So let's go into the solid papillary carcinoma and the encapsulated papillary carcinoma category. So this actually is the recent sort of change or development in the papillary field. So solid papillary carcinoma, you call something solid papillary when you see this clustered or large nodules of almost like DCIS that are back to back or arranged like zigzag fashion, and they seem to be embedded in this most of the times in pink fibrous stroma. And if you pick the typical histological features are these thin fibrous septi that separate these broad nests of tumor cells. So high power picture, they can have they look like lobar DCIS if you go to the individual nodule, and they can have cribriform appearance. If you pay attention, some of them may have the cells, they may have a little mucin. So if you do myopithelial stains, most of the myopithelial cells may be completely absent, reduced, or focally present in the periphery. So P63 shows complete loss as compared to adjacent duct that shows intact myopithelial cells. So smooth muscle myosin shows actually there's something to know is smooth muscle myosin also stains the pericytes. So that's sort of a pitfall while interpreting smooth muscle myosin heavy chain. However, it's negative in the atypical papillary lesion. So that would make it sort of lack of myopithelial cells. So you wonder whether it's invasive or is it inside it. So more features of solid papillary carcinoma, some of them, they may have a lot of mucin. So they are associated with actually mucinous carcinomas. They have neuroendocrine phenotype, which can be demonstrated by chromogranin and synapto. Sometimes you can see intact myopithelial cells and focally in these. As compared to SPC, the encapsulated papillary carcinoma is morphologically distinct. It has a thick fibrous capsule. And other term for encapsulated, the sort of more traditional older term is intracystic carcinoma. So it can have some cystic change. And if you go to the individual fibrovascular papilla, it looks like a papillary DCIS. There are no myopithelial cells in the fibrovascular cores. And you can demonstrate it by the immunostains. P63 shows lack of myopithelial cells in the fibrovascular cores or at the periphery. There's one caveat that the tumor cells itself can stain for P63, but you can differentiate it by looking at just by the size of the cells that are staining. Myopithelial cells are small. So what are these tumors, SPC and EPC? They are considered as invasive tumor with excellent prognosis. So the WHO says that in absence of any conventional invasive carcinoma, you can actually treat them as DCIS. So, however, there have been rare case reports of these tumors getting metastasized to the lymph nodes. So what you are looking for is, if you have made this diagnosis of SPC or EPC, is a focus of conventional invasive carcinoma, like infiltrative destructive invasion, and which actually shown in this circle. And there is SPC in the vicinity of this proliferation. So what I'm telling you is, like, if I think for board's perspective, you can call, based on those features, you can call proliferation as solid papillary carcinoma, but also look for focus of invasion. Why is this important? So you will be staging the tumor based on the size of that conventional invasive carcinoma. And you will put the rest of the solid papillary carcinoma or encapsulated papillary carcinoma as DCIS. And this would need a note, sort of, in your, if you're making a report while you're practicing. And most of these are low-grade, they're ER positive, the SPC and encapsulated papillary carcinoma. However, recently there was this paper about on the solid papillary. So you can actually see a solid papillary pattern in an invasive tumor. So how would that be different from your classical solid papillary, which you can treat as DCIS? So the tumor nests, they are smaller. They are irregular shape. They are separated by more fibrous stroma, and they have jagged borders, and you will see desmoplastic response. It's rare, but something to know that there is an invasive solid papillary carcinoma. So moving on to a couple of other things that are common in papillary lesions, something that you should know. I don't know if they're going to test it in boards. I actually don't know. But there's a phenomenon called epithelial displacement, so in which you find these epithelial cell clusters at the biopsy site right next to the papillary lesion. It is secondary to the core-needle biopsy procedure, and it's very frequent with papillary lesions. So the pitfall is, if you're going to say, oh, I'm seeing epithelial cells embedded in the stroma, maybe it's invasive tumor, and you do P63 and smooth muscle myosin, they will be negative for that. So, but it's a pitfall. It's an artifact of core-needle biopsy. Oops, sorry. So high power picture. So what makes them displaced epithelial cells? The morphological features. They're evenly dispersed. They're like shotgun distribution, and they're rounded, pink, degenerated cells. You can see it in the biopsy tract all the way through. Other artifact is, you can actually see the displaced tumor cells in the vessels. So they will be degenerative looking. They might be associated with hemosiderin, and they will be near the biopsy tract. So what we have talked about is the distribution of myopithelial cells in EPC and solid papillary. Something to remember is that in EPC, the myopithelial cells are absent in both, in the vascular cores as well as the periphery. However, in SPC, you may see focal myopithelial cells at the periphery. And what makes it diagnosis of SPC is the constellation of the histological findings. And one thing which I forgot to mention is, both these tumors you see in postmenopausal women in 60s and 70s. So if you're making a diagnosis of SPC or EPC in 40-year-old in the board, just back off and think maybe it's papilloma with DCIS. So we're out of the true papillary lesions. Invasive micropapillary carcinoma. I just want to touch base on it because I think it has a very typical morphological features. So this is invasive micropapillary carcinoma of the breast, and what makes it micropapillary is this typical reverse polarization of the tumor cells. And typically the tumor cells are dense. There are a lot of tumor cells in very less area. Each cell cluster makes this micropapilla with reverse polarized tumor cells, by which I mean that the luminal surface of the normal cell is actually towards the stroma, and nuclei are towards the center of that micropapilla. And you can typically they're floating in this empty space or retraction cleft. And EMA, you can highlight this reverse polarity by EMA. This is a commonly used immunostain. There are a bunch of other markers which you can do, but this is the most easy. So EMA stains the peripheral border of the micropapilla. That would pin it down as invasive micropapillary. There's a mucinous type of micropapillary, something to know, and you have the same reverse polarity in the micropapillary clusters that are floating in the mucin. One other thing that is worth mentioning is that these tumors are more frequently HER2 positive. Up to 50 to 55% are reported in some series to be HER2 positive. But at the same time, if you do IHC, they have this peculiar basolateral staining, which would not make it to 3+ and rarely to 2+. So what is suggested is that, or recommended by CAP actually in the guidelines, is if you're looking at a micropapillary and you are about to call it 1+, and it is a basolateral staining, reflex it to fish. So it's written in the guidelines. So it's important to identify this variant and then think about it when you're doing the HER2 staining or HER2 assay.
What the marker you used to stain the previous IHCs?
That's the epithelial membrane.
Oh, epithelial.
EMA, yep. So next, let's go to the fibroepithelial lesion. I think that's another big subject. Itself can take like, I don't know how many hours. So I'll go straight to this table. So it's from WHO. I don't know. I hope that you guys have seen it. And it's page 145. And I stick to this table. And that's how I was trained. Stick to this table. I think the most important critical thing when you're evaluating a fibroepithelial lesion is to make the distinction whether it's a fibroadenoma or phylloides. Once you have done that, then you grade the phylloides. And according to WHO, I think there are a bunch of schemes how you grade the phylloides. There's a low grade, high grade, but WHO recommends benign, borderline, and malignant. So I think there is a good agreement in diagnosing malignant phylloides. Beyond that, people can go in every different direction, but I think boards will keep it simple if they do give you a fibroepithelial lesion. So we'll just go over a few cases and see how we get to this grading of phylloides. I'm not going to show you a fibroadenoma because I think fibroadenomas we see a lot, but phylloides are something that are rare and we don't see as many. So they all have the same history. 50-year-old, 55-year-old, 4-centimeter fully defined lesion. And the critical thing I said is the evaluation of the architecture. And there are a couple of things. Phylloides, I mean, it's a leaf-like architecture, intracanalicular pattern. You want to look at the distribution of the stroma. In phylloides, you'll see this condensation of the stroma around the epithelium. Presence of a fat is not good in a fibroepithelial lesion. You can see in a fibroadenoma, but start thinking about a phylloides if you're seeing a fat inside a fibroepithelial lesion. So that's the low power examination. Then you go to further, one more other important thing in evaluation of fibroepithelial lesion is the border. So fibroadenoma, the borders are circumscribed. Benign phylloides, the borders are circumscribed, pushing type. However, the moment you start seeing these permeated borders where you see the stromal cells sneaking into the fat, it's a focally permeative lesion and you are at least at the borderline phylloides. There's no way you can go back to benign phylloides. So at the same time, other feature that helps is the heterogeneity in the stroma. Fibroadenoma, I think it's difficult to apply, but fibroadenoma, the stroma is sort of relatively homogeneous in cellularity. However, in phylloides, you will see this variation in the degree of cellularity. As you are seeing here, like there's a lot of cellularity around this duct as compared to this area, which is more fibrous. More leaf-like areas, which are actually diagnostic of phylloides. That's a cellular area. It's like mild to moderately cellular. I don't see any mitosis, but it's very cellular. Make you think of phylloides. So if you have to use all those features, since it has permeative border, let's look at the, so I mean, it's not malignant based on the findings. So either you're arguing between benign and borderline, and based on permeative border, I'll put it as a borderline. So moving on to the next one. This is another fibroepithelial lesion.
We don't use the mitosis for the line.
The cutoff is 5 to 9, I think, or 5 to 10. But 5 to 9 per 10 power feet. But mitosis, I will tell you, is something that I go for last. It's like the last resort. So when you have to bump something from benign to borderline, I will use mitosis as the last. Most of the times, typically, it's the border and the stromal overgrowth that kicks first. But that's not like never say never. But yeah, you do look at the mitosis, and if you're seeing very frequent mitosis, you do pay attention to the border and everything. So let's go on to the next one. This one is another example of phylloides where you see this prominent leaf-like architecture, and you don't see very cellular stroma at the low at this magnification. However, the architecture is prominent. Makes you think of phylloides. So focally, it does get into the adjacent fan, focally permeated border. However, otherwise, I don't think it shows stromal overgrowth. Or let's go to the, I think I might have a high power picture. So there you go. So some people call it tenting, or like creeping into the adjacent fan, microscopic permeation. So that would make it at least borderline. So the reason, if you read the chapter, the reason the borderline, what makes anything borderline is like, we are not sure this is going to act like benign or malignant. It doesn't mean that it's going to act like malignant. We just don't know because of the features. And most of them actually act like benign. Most of them.
How about atypia? What?
Nuclear atypia?
Yeah, stromal nuclear atypia. What like triggers you to put it like in, like maybe if it's circumscribed but it's got a lot of atypia in the stroma?
Usually they go hand in hand. If there is a lot of nuclear atypia, I have a case where there is a lot of nuclear atypia. So we're gonna look at that. So this is another case where the border is well defined, which you can see right here. And I just wanted to stress this, the stromal overgrowth. Usually it's like one area of 22.9 square millimeters. It comes from a paper in which you don't see any epithelium, and it's like a low power 4x. So if you have that, you can call it a stromal overgrowth, and that will put it in at least borderline category. So again, you can appreciate the leaf-like architecture, which will make it phylloides. There's some heterogeneity in the stroma. However, it doesn't look very cellular. It's very fibrous, and there's no mitotic activity. So this one, there's focal mitotic activity. There are a lot of neutrophils. So I think it can go either way, benign or borderline. You can call it borderline if you think it qualifies for the stromal overgrowth. However, the margins were circumscribed. So this one is an example of benign phylloides. So just in case if you're arguing whether it's a benign fibroadenoma versus phylloides, so you have this typical intracanalicular pattern with sort of evenly cellular stroma, which has this very myxoid appearance. Pushing borders doesn't infiltrate into this adjacent parenchyma, but the stroma is prominent. High power, there's no minimal atypia, if any, and the cellularity is even. So I guess you can call it benign phylloides based on the overall features. This is a picture from a juvenile fibroadenoma, because this comes into picture whenever you're dealing with fibroepithelial lesion with very cellular stroma. So the differential is cellular fibroadenoma or a juvenile fibroadenoma. So juvenile fibroadenoma, everything goes hand in hand. So you will see epithelial component is also proliferating. So you can actually appreciate in this. It's like a UD edge, and at the same time the stroma is very cellular, and it's evenly cellular. So that would make it sort of a juvenile fibroadenoma. So this one is a malignant phylloides, and low power picture. It's very cellular, leaf-like architecture, and it is permeating into the fat at this end. Heterogeneity in the stroma, and these areas are really cellular. So basically, if you're looking at a phylloides and you're thinking of a low-grade sarcoma, you are, if the stroma looks like low-grade or high-grade sarcoma, you're into this malignant sort of category, borderline or malignant. One other thing that is in the footnote in the table is that if you have a liposarcoma, rhabdomyosarcoma, a heterologous element, it's a malignant phylloides, no matter what the mitoses and everything else is. So looking at a couple more pictures from this. So this is very cellular stroma, and it's like moderate nuclear atypia with a lot of mitosis. So this will be a malignant phylloides. So out of fibroepithelial lesion, sclerosing adenosis. So I got this also as a topic. I don't know. So it's an incident. Most of the times it's an incidental finding, And what it is the central part of it's a TDLU based lesion. So one entire TDLU will undergo sclerosing adenosis. So the central part of the TDLU, the lumen, they're obliterated and they're sort of flattened, and rest the peripheral part of the lobule, it undergoes sort of swirling around. It's a benign process, so but sometimes it can form a mass. Like multiple foci of sclerosing adenosis, they're together, and you call it nodular adenosis or adenosis tumor. It can present as a mass. Next is, I just gave you a little bit of history. 45-year-old with asymmetry with no ultrasound correlate. So whenever there is a question of asymmetry, and if you're in exam, I'll think of a radial scar or a lobular neoplasia or lobular invasive lobular carcinoma. Those are the two things that will come to my mind. And this is a black and white picture. I like this picture, so I have to put it. So it's a radial scar, and what makes it radial scar is this central fibroelastosis, which contains this haphazardly arranged tubular structures, and everything else sort of radiates out from the central structure. So this entire findings, like group of findings, make it radial scars together in this particular configuration. Another picture of radial scar with fibroelastosis, and usually they are associated with the usual type ductal hyperplasia, cysts, and sometimes micropapillomas. More pictures of the radial scar. This is in a biopsy, so apparently there has been discussion like, do you really need to excise it? So if it's a target lesion, you will get excision, because many of these are associated with low-grade carcinomas, tubular lobulars. And what would make you suspect that? If you see these tubular structures in the fat, like, and without any myoepithelial cells, you will obviously do myoepithelial stains, and they will show lack of myoepithelial cells. But however, the caveat is, if the structure, the epithelial structure, is within the fibroelastotic stroma, some of these can show loss of myoepithelial cells. They just inherently don't have it. So just be careful if you're doing a lot of myoepithelial. That's a caveat, basically. You cannot call it invasive unless you have a overtly infiltrative process outside the fibroelastosis. Another example of radial scar. Other thing is there's something called incidental radial scar. So that really not is a target lesion. So you can actually spare an excision if it's an incidental small radial scar. And obviously you need the red-pat correlation. Sometimes the central part can be cellular of the radial scar. This is another example of with the cellular central area. They can be big. So if it's more than 1 centimeter, you can call it complex sclerosing lesion. And that definition actually comes from radiology literature. Poorly, so moving on to the next case, a 45-year-old with poorly defined left breast mass. This was an excision. So what you see is diffuse proliferation of small glands. And you don't see any like big difference in architecture. Most of them, they look similar, same size, and they're diffusely infiltrating into the fat. High power picture, you do notice that some of them have this pink secretion. So that makes you think of microglandular adenosis. So the reaction would be to exclude an invasive carcinoma. Myopithelial cells, they will be absent. Smooth muscle myosin will be absent. What you want to do is S100. This will be S100 positive. And if you are really worried about invasive carcinoma, then you can do ER. So low-grade carcinoma will be strongly ER positive diffusely. So that would exclude the low-grade carcinoma. So S100 stains the myopithelial cells too. So they can undergo apocrine change, and they can undergo a typical proliferation leading to the carcinoma. And most of the times they are triple negative basal type tumors that arise from MGA. So that was MGA versus tubular carcinoma. This is an image from a typical tubular carcinoma. So what makes tubular carcinoma is, again, combination of findings, which includes the architecture of the glands as well as the stroma. So, I mean, you can have more than 90% tubules in a grade 1 invasive ductal carcinoma. That won't make it a tubular carcinoma. What makes it tubular is this angulated open glands with this evenly cellular desmoplastic stroma. So if you compare this stroma with this outside the tumor, it's very cellular. And typically, the tubular carcinoma will be arising in a setting of flat epithelial tibia, typical ductal hyperplasia, which you see it in this picture. So this is flat epithelial tibia. And if you have a lobular neoplasia too, that would make it a so-called Rosen triad of columnar cell lesion, tubular carcinoma, and lobular neoplasia. More pictures comparing the stroma between the tubular carcinoma and the benign breast tissue. They have the snouts, the cells in the tubular carcinoma. So, yeah, they are ER positive and HER2 negative, something that related to the CAP guidelines that you want to know. More high-power pictures of tubular carcinoma, flat epithelial tibia. I'm not going to go show more pictures of this, so they are associated with FE. Picture of next case, gynecomastia. I think it's important. I mean, the history will be obvious, but I guess what if they don't give you any history, what you have to tell is that it's a male breast, and you don't see lobules. What you see is small ductules, and what makes it gynecomastia or gynecomastoid change is the usual type ductal hyperplasia, in which they look like these micropapillae or snouts, which are different from the micropapillary ADH. The nuclei, they get smaller as you go into the lumen. So the nuclei at the base, they're broad at the base, and the nuclei also get smaller as you get into the lumen. And many nuclei, you'll see they're sort of lying flat, parallel to the basement membrane. That also you see in this gynecomastoid UDH. And at the same time, you'll also see this patch-like, very cellular proliferation in the stroma. So overall changes in the stroma and the duct make it a gynecomastoid, or gynecomastia or gynecomastoid hyperplasia in a female breast. More picture where it gets a little florid. So atypia in gynecomastoid hyperplasia is very rare, or ADH, it's extremely rare. So if you're about to make the diagnosis in the board, just stop and think, could it be just florid gynecomastoid hyperplasia? Diabetic mastopathy. I didn't have a picture. I just took it from one of the papers. So classical histological findings are there are 5 features. There's a dense lymphoid aggregate around the lobule, around the ducts, and around the vessels. And there's associated keloidal collagen and epithelial myofibroblastoma. So that's the classical features of a diabetic mastopathy, a lymphocytic mastopathy. So, but it was originally described in type 1 diabetes, but it's also seen in type 2 diabetes or any other autoimmune process like Hashimoto thyroiditis or any other. So it doesn't clinch the diagnosis of diabetes, but I like lymphocytic mastitis, and then say if there's a history of diabetes, this would be consistent with diabetic mastopathy. And they can present as a mass. It can be recurrent, and people have had mastectomies because of this. And the other finding is pain. PASH, typically the findings are very typical. They look like gynecomastoid, but you have to focus on the stroma. So they have, in the stroma, you'll find these pseudovascular spaces and with nuclei hanging onto the edge. And if you look at the PASH under frozen, they're actually supposed to be filled with some matrix mucin. So, and while the processing, it gets washed off. So that's the PASH. So it can come in 2 flavors. One is this, where it doesn't form a mass, and it's just diffuse, incidental finding. Second is nodular PASH, where actually the patient will get a targeted biopsy of the mass, which is PASH. If you have any ambiguity about the diagnosis, you can stain it. It would be CD34 positive, BCL2 positive. The cells will express the receptors, the ER and desmin. CD34 is positive in this. So yeah, it's actually a caveat. What else? So and there are some variants to the PASH. There can be a fascicular PASH, which can look very cellular, and there can be some nucleotypia in PASH, but I don't think it's relevant for the birds, but just for the more pictures of the PASH. So PASH is a disease of premenopausal women. So if you are in a postmenopausal setting around mass that looks like a PASH, you're looking at a myofibroblastoma. So this is a core biopsy of a myofibroblastoma. It looks like PASH, but there are no lobules. So it's sort of difference between PASH and myofibroblastoma is it's PASH you will find entrapped lobules within the PASH areas. While myofibroblastoma is the immunoprofile is same, but it just pushes out the lobules. And you can see this, the immunoprofile is similar, and you can see all the changes that you see in PASH in myofibroblastoma. And this is also CD34 positive. Typically, it can be CD34 negative, and some that have myxoid change. You can have epithelioid change, which can look like a lobular carcinoma. I don't know if I have one more high pictures like this one. It can be very epithelial. You can have cartilaginous metaplasia in this. So postmenopausal mass that looks like PASH, myofibroblastoma. Something that comes in differential is angiosarcoma. So primary mammary parenchymal angiosarcoma is extremely rare. So you will probably encounter a post-radiation angiosarcoma, and they are tricky. So this is a case of low-grade angiosarcoma. So what you would appreciate is there's a skin, and in the dermis you have this very diffusely infiltrative proliferation, epithelial proliferation, which, if you go in high power, you see that the epithelial cells, they're making spaces, mimicking the sinusoids or vessels. And the diagnosis basically rests on this infiltrative process, which you will prove that they're vascular, and the nucleotypia. You may or may not find a mitosis. So this is low-grade angiosarcoma after radiation. More pictures, very dissecting through the collagen, and may look very bland. But what would help in both is the history. That patient had a history of lumpectomy with radiation, and now she presents with this vague fullness of, involving the skin after 3 to 4 years. This is another example of a high-grade angiosarcoma after radiation, and this is overt. So it's involving the subareolar region. You can see the almost spindled proliferation, dissecting involving the entire dermis. So the key here is nucleotypia. They can look epithelioid or spindled. They are forming this vague sinusoidal structures. They are mitosis. It's malignant, extending up to the dermis, diffusely involving the periductal tissue. And the diagnosis will rest on immunostains. So you'll have to stain it, prove it's endothelial, CD34, CD31, ERG, to call it a high-grade angiosarcoma. One lesion that is worth mentioning is AVL, a typical vascular lesion. I don't know if you have.
Question for the angiosarcoma is a MIC stain useful for that or not?
Which stain, sir?
MIC.
MIC stain. Yeah, I'm going to come to that.
Okay.
So basically, MIC is useful. So if you have a question, so in post-radiation angiosarcoma, they have usually MIC amplification. So you can demonstrate it by FISH or by IHC. So this is another vascular lesion that you see in a setting of radiation, a typical vascular lesion. It usually presents as a small papule, multiple, or single. And if you biopsy it, what you will see is telangiectatic dilated vessels with maybe mild nucleotypia. They don't cluster, they don't permeate. But if you have this, you say, and there's no overt cytologic atypia mitosis. So the features of angiosarcoma are lacking. So what you want to do is completely excise it, because you cannot really entirely rule out a low-grade angiosarcoma. So, or I don't think it's already there, like doing a CMIC. So basically, what you can do is also do a MIC, IHC or FISH. And based on this paper, in their experience, all the AVL except one, they were negative for MIC, and there were one that was positive, developed angiosarcoma. So it's helpful. if you are stuck. Going to lobular neoplasia. So this, I'll start with ALH. So I'll just go over how do you differentiate ALH versus LCIS. So on the right, you have a lobule that is involved by a typical lobular hyperplasia, and on the left, there is a relatively normal lobule. So what makes it ALH is you can see this this epithelial proliferation that has pale cytoplasm. It looks disheesive and almost like fried egg. So why is it ALH? It's partially involving a lobule. So there are three things: partial involvement of a lobule, if the lobule is not distended as compared to the adjacent benign lobule, and if you can still see the lumina of the involved lobule, you're looking at ALH. The pitfall would be like myoepithelial cells. Sometimes they can undergo clearing, so you don't confuse them with lobular neoplasia, especially during the second phase of the cycle. High power picture, better view of the ALH. Disheesive cells, low nuclear grade ALH. LCIS, you will see complete distension of the acini, and the involved acini will be larger than the adjacent benign lobule. Another picture of LCIS. The architectural feature that is peculiar about LCIS is this cloverleaf pattern when it involves the duct, the pagitide involvement of the duct. Variants of LCIS, there is a pleomorphic LCIS, which, as per current WHO, the definition is if the LCIS looks like high-grade DCIS, you can call it pleomorphic LCIS. In this picture, you have classical on the left and pleomorphic on the right. Another picture of pleomorphic LCIS. For boards, I think if they do ask this, they might say it's triple negative, ER negative, or HER2 positive, because when you get into this pleomorphic category, you get out of this ER positive and HER2 negative zone. So the pleomorphic LCIS can be ER negative, triple negative, or HER2 positive. Other markers are c-MYC amplification. You can use that, but it's not in use. You make this diagnosis by morphology. Other variant is florid LCIS, which you can easily confuse with the DCIS. And what makes it florid is the extensive extension or dilatation of the involved TDLU. And many times they will have a central necrosis. So how will you diagnose it? Go to high power, look at the cells. They are low grade or intermediate grade cells, similar looking and disheesive. And you can do ECAD or P120. So E-cadherin can help. In 85 to 86% of cases, it will be negative. But in 15% of cases, you might see some expression, weak expression. Like in this case, this looks like a pagitide involvement by LCIS, but there is some expression of ECAD, but it's weak than the adjacent luminal cells. So what you can do is P120. So if it's lobular phenotype, there will be cytoplasmic localization of P120. So this is the ECAD on the same case. So there is some focal ECAD expression in this tumor, which is actually a lobular. As compared to in ductal, there is the P20 is expressed on the membrane. Another quick one, Mucocele-like lesion. I think it's something that has come up in the recent years, on which actually the community has sort of achieved a consensus that. So what is Mucocele-like lesion? It's just like in salivary gland. It's the extravasation of the mucin, acellular mucin pools in the stroma. And why are we seeing it more often? Because it is associated with calcifications. So we're sampling more. This can be related to FEA, ADH, or DCIS. So the next decision is based on whether you just have a Mucocele-like lesion associated with a benign process, a duct, or like ruptured duct, or is there anything more in the biopsy? This one is just benign duct, ruptured duct with Mucocele-like lesion. This one actually was associated with ADH. So this will get an excision to exclude any further atypia. Bridges. Yep. Very minimal. That's all you need. Paget. I think melanoma of the nipple is extremely rare. So if you have a biopsy from the nipple with this, even if they contain melanin pigment, I think the first differential is patched, and the stains that you can do to pin it down is CK7 and HER2. Most of these are HER2 positive. You can also do mucin, CEA, GADA. Although there is a CK7 negative patch reported in the literature, so just keep that in mind. Inflammatory carcinoma, presence of LVI in the dermis doesn't make a tumor inflammatory carcinoma. It's a clinical diagnosis. Something to, I don't know if they still ask this in the boards. They do.
The same phrases that were. If you see like a lesion inside the lymph, does that make the inflammatory?
No.
No, it's just based on staging, like they ask staging and all
Yeah,
this information.
it's a clinical staging. It's not. But usually what they do is if they suspect inflammatory, they will do a punch biopsy. But if it's positive or negative, it won't decide whether it's inflammatory carcinoma. Medullary carcinoma is out of fashion. WHO has something carcinoma with medullary features, and I don't know if they might ask you. This is not medullary. This is something I took a picture that looks like medullary. So the nuclei are high grade. They look like syncytium. They have prominent nucleolus, pushing border, and there will be tons of lymphoplasmacytic infiltrate. That would make it a classical sort of medullary with triple negative markers. Last one, silicone. Medullary is usually triple negative. But the medullary is out of fashion because the idea is many of these are associated with BRCA. And when you have BRCA, you think of medullary, they can be ER positive. So it's not black and white. So this is the last one. So brief history, the patient has history of bilateral mastectomy with implant reconstruction and implant placement. And she develops a new density in her breast. And this is a biopsy of the density. And I don't know if you have seen a case of silicone mastopathy. So basically what it looks like is you have skeletal muscle and you have these variable size round spaces, which look like lipocytes, adipocytes, or lipoblasts. And there might be giant cells and histiocytes. So the key is you flip your condenser and the things will look refractile. So that's the implant material. The giant cells can have asteroid bodies in this. Another case where you have the implant and silicone mastopathy. Case nice, an asteroid body in the giant cell. Flip the condenser, you'll see the material. You can have the lymph nodes involved with it too, and actually it can go. There are reports of silicone being present in different parts of the chest. So flip the condenser and see the material. That's it. That's all I could, collect. Thank you.
Thank you, Dr. Singh. We have a question from online audience.
Sure.
There is a question from Wail Abudaif. So he is asking, can we have slides about the scary changes in male gynecomastia and how to differentiate florid atypical hyperplasia associated in male gynecomastia from carcinoma?
Okay. Well, all I would say is that I'll just repeat what I said. Like finding atypical ductal hyperplasia in a setting of gynecomastia is extremely rare. It's like extremely rare. So, I mean, all I can recall is I had a case as a fellow which got close to that, but that's the only one case that I've seen, and I was told that just like what you do in a florid papillomatosis of nipple, which is another situation where you can get very florid hyperplasia. So just back off from that atypia or DCIS diagnosis unless it's overt. So I guess I can try to find a case, or it would be a case report if it is a case of DCIS arising in a setting of gynecomastia. And that's one of the reasons why male breast cancer is detected at a higher stage. Like rarely we pin it down at the in situ or atypical stage in male breast. So I don't know if that is satisfactory answer.
I have a question. Oh, thank you so much, Dr. Singh. I have a question. So how do you differentiate juvenile fibroadenoma from benign phylloides, disregarding age, on morphology? Like because in juvenile fibroadenoma also you can have a very cellular stroma, right? So how
Right.
do you differentiate it from a benign phylloides?
I think that's a good differential. So in a phylloides, you will see the diagnosis of phylloides will rest on the architecture. First,
Mm-hmm.
it will show a prominent intracanalicular pattern, leafy architecture,
Mm-hmm.
and the stroma will be cellular.
Okay.
However, as compared to phylloides in juvenile, you will see evenly cellular stroma. It will be very cellular, but it would be evenly cellular.
Okay.
Yeah, and I think sometimes it can be tough, to be honest with you. And
Mm-hmm.
people have done studies, and one that I recall of is done by Dr. Giza Axe, and he showed that, and he collected, I don't know, there were 10, 12, or 15 cases, and people diagnosed same case as fibroadenoma to borderline, and these were the cases which he had included in his study. So I think it's tough,
Mm-hmm.
but yeah, age definitely helps. And whenever you get a fibroepithelial lesion, I think, and you can have phylloides in young women, but still, if you have a 18-year-old with this evenly cellular stroma, with proliferative epithelium, with no intracanalicular pattern, and the stroma is far less, there's equal amount of epithelial component, I think you can call it juvenile fibroadenoma. That would help.
Oh, okay. Okay. Thank you. There is one more question online. So, Iman Al-Asadi has this question for you. How to differentiate between UDAs and DCIS?
Okay, so I think we went over the morphological findings. Like if you think it's ADH, it will form. If the proliferation is low grade, then you will find this well-formed acini, and the cells are monomorphic. And as compared to in UDH, you will see the spaces, they are variable size, variable shape. The cells will be streaming, and
Mm-hmm.
if that doesn't, and I guess he's talking about ambiguous, then you probably have to go to immunostains, and you throw CK5-6, which will be mosaic. There will be cells that are positive, cells that are negative, and at the same time, in ADH, there will be complete loss of CK5-6, and ER will be strongly, evenly positive in that epithelial cell. That would make it DCIS or ADH.
So, CK56 will help to differentiate between ADAs and DCIS, right?
That actually that would help in a papillary lesion. So once you have made a diagnosis that it's a typical proliferation, then you have to look at the overall features, that how much it is. So if you're in a low nuclear grade process, the criteria is that you have 2 ducts or 2 millimeter span of a typical proliferation that is totally filling the ducts. You can call it DCIS, low grade DCIS.
Mm-hmm.
However, if you are in a papilloma, the span is 3 millimeters. So if you have floor like wall to wall ADH that spans at least 3 millimeters, that qualifies for DCIS.
I see. I see. Okay. So thank you. There is another question again from Wail, so who had the previous question about gynecomastia. He thanks you for answering his previous question. So he also wants to know if we have mitosis and micropapillary proliferations with clinging pattern and atypia, what will be your diagnosis?
I think I mean, I'll have to look at the slide, to be honest with you. Basically, you're talking about, the question is, I'm just talking to my residents here because they can't hear the question. So the question is really, I think what he's talking about is how to make a diagnosis of clinging carcinoma. How much atypia do you need? How do you differentiate sort of minimal epithelial proliferation that looks really atypical? Would you call it clinging carcinoma, or you just, what do you call it? I think clinging carcinoma is reserved for like high grade DCIS. So the nuclear atypia will be of high grade DCIS. And then you have mitosis, you call it clinging carcinoma. I think that, I don't know if that was the question. But the way I think the question was posed, I think yeah, I mean those are all the features that I'll use. Yeah, and most of the times there is necrosis in the clinging carcinoma. The center of the duct has nucleus debris, the debris like necrotic debris, that would help too.
Right. So what is still like, is there any change about the criteria? But this is a different question that I have, that about extensive DCIS. Do we still have the same criteria like before, or there is any change?
No, I think the criteria are same. The question is, what is the criteria about EIC? Is that the right reference?
Right.
So extensive intraductal comment. I think the criteria are same, and they are listed in the
25%?
yes. However, yeah, I think the age, the time when we used to use it, I mean, it's more used when you have a, extent like a small tumor and the margins are close. In that cases, it's relevant. However, if the margins are widely negative, I think it may not apply. But yeah, I think the criteria are same.
Okay, I see.
I guess
Anyone has any more questions?
I think one of our resident was asking me how to differentiate papilloma with DCIS versus papillary DCIS. And I'll just go back to the table where you have to look at so papillary DCIS is rare. It's very rare. I think it's sort of vanishingly rare. Papilloma involved by DCIS is common. So what you want to see is, and typically you will see features that of a background papilloma. So if it's partial, but then you're talking about how maybe it's completely run over by DCIS. So if you do myopithelial stains, you will see the myopithelium within the vascular course as well as at the periphery. But you will not see the myopithelial cells within the DCIS portion that is involving the papilloma. That would help you to pick up that background papilloma.
Okay, so you said one thing that medullary carcinoma as a terminology is not encouraged anymore.
No,
So
I don't
like,
think so.
you just have to say that it's invasive ductal carcinoma with medullary features, right?
That would be the WHO terminology, carcinoma with medullary features.
Okay, and the moment you see medullary carcinoma or like the invasive carcinoma with medullary features, do you suggest for BRCA1 status, or you do not?
No, I don't think so. I mean that decision is usually taken in as a team based on the patient age and the family history and all that.
Okay.
Yep.
Okay. All right. Thanks again. Thanks so much. I don't think we have any more questions. And if anyone has, of course, feel free to write to us, or feel free to write it as a comment on either YouTube or on Facebook. So you're more than welcome. And thanks again, Dr. Singh, for your time. And we really appreciate it. Thanks so much.
All right. Thank you for the opportunity.
Sure. You're welcome.
All right.